Real life, please.
A very good evening, everyone. Welcome to the Retinoblastoma They Live and See 2026 Masterclass. As we all know that we celebrate the Retinoblastoma Awareness Week in May every year, and we celebrate it from 10th to 17th of May this year. And I welcome you all on this session, that is the masterclass. And it is our distinct honor to welcome the chairperson for today's session for Retinoblastoma Awareness Week, Padma Shri Dr. Jeevan Singh Titiyal sir. A luminary in the field, Dr. Titiyal's illustrious career has been crowned with the nation's fourth highest civilian honor, the Padma Shri, awarded to him in 2014 for his transformative contributions in the field. Revered as the first Indian surgeon to perform a live cornea transplant on the global stage, he has pioneered groundbreaking advances, including India's first intact procedure for intricate corneal disorders. His mastery spans keratoplasty, refractive surgery, stem cell transplantation, and so on, illuminating countless lives with the gift of sight. A guiding force in the Indian ophthalmology, he is the president of the All India Ophthalmological Society, and we have all witnessed his shining career and tenure at AIMS, and he continues to lend his unparalleled expertise as a leading consultant at Dr. Agarwal's Eye Hospital, New Delhi. With decades of service marked by clinical brilliance, academic leadership, and dedication to community eye care, Padma Shri Dr. Titiyal sir embodies the spirit of vision and compassion that we celebrate today. So let us extend a warm and reverent welcome to Dr. Titiyal sir, and sir, I request you to say a few words.
A very good evening. Thank you, Rolika, for a nice introduction. I think, as we have grown into the medical science, there has been so much improvement in diagnostic equipments, diagnostic tests, as well as treatment facilities. I remember my days when I was a resident doctor at RP Center AIMS. In fact, during my senior residency, also I handled a lot of retinoblastoma patients because one of the segment in our unit was pediatric ophthalmology, and treatment at that time was just evolving. Apart from the enucleation, in most cases, we could just transform ourselves into a radiotherapy, and that to a barely getting into accelerated targeted radiotherapy at that time. And more often now, if I see the journey of people suffering from retinoblastoma, one of the most common intraocular tumor in children, the things have changed so much. I think, as rightly this masterclass points, like they see and they live. And person who's going to give this masterclass today, Dr. Santosh Honabar, who's really done so much of work in this field, and we actually are, very proud that in India we could achieve so much for these kids, and they come from a social background which is classically in a poorer social background. The treatment can be difficult for the family, and the recent advances which has happened can sometimes be challenging also. So I appreciate this masterclass will definitely give us the right avenue to diagnose these kids, to counsel the family, to support these families, so the treatment can be done the right way, and we can save their life and save their vision also. And I surely hope that people who are attached to this masterclass are going to take this masterclass subsequently also. They're going to benefit immensely with the caliber of teacher we have, Dr. Santosh Honabar. Thank you, Rolika. I think, it's going to be a great session today.
Thank you, sir.
Thank you so much, sir. Thank you so much, sir, for your kind words, sir. And before I introduce our speaker for the day, I would like to also introduce our panelists, Dr. Farnaz Yazir, Dr. Megha Banka, Dr. Mahima Kaushal, and Dr. Anupama Amatya. They're brilliant and budding minds, and we are really proud to have you on board. And it is with great reverence and pride that we present our distinguished speaker for today's Retinoblastoma Awareness Week session, Dr. Santosh Gajanan Honavar, a true visionary who has revolutionized the face of retinoblastoma in our country. Dr. Honavar has transformed the destiny of countless children battling with this formidable cancer. He is the mastermind behind the orbital retinoblastoma classification and management, which is practiced worldwide, whose pioneering protocols have become the cornerstone of care across India and beyond. And to his credit, he has crafted multimodal strategies that turned despair into hope, bringing the survival rates above 90% for over 4,000 young lives that he has personally guided, par socioeconomic status. Adorned with the Shanti Swarup Bhatnagar Prize, India's high scientific honor, Dr. Honavar holds the rare distinction of being the only Indian ophthalmologist to receive both the Lifetime Achievement Award from the AAO and the Honorary Fellowship of Royal College of Ophthalmologists, London. As the Honorary General Secretary of AIOS, Director of Medical Services at Centre for Sight, and Director of Ocular Oncology and Oculoplasty at Centre for Sight for Hyderabad, and the Director of National Retinoblastoma Foundation. He stands as the architect of ocular oncology in India. He established the nation's first dedicated ocular oncology service at LVPI, and he continues to be a mentor, scientist, and healer of extraordinary stature. Dr. Honavar ranks among the top 2% of researchers globally and leads Indian ophthalmology with unmatched brilliance and compassion. Today, we are deeply honored to learn from the very force who redefined retinoblastoma care in India. Over to you, Dr. Honavar.
Thank you so much, Rulika. I'll share my screen. That was very elaborate.
Also.
Okay. Can you see my screen? Yeah?
Yes, sir.
All right. So I'll be talking about Retinoblastoma 2026. They live and see. This is a kind of become an annual routine for us to update on retinoblastoma on every Retinoblastoma Awareness Week, and the Retinoblastoma Awareness Week for 2026 begins today. So we are well on time to listen to retinoblastoma and what new is happening in the field of retinoblastoma. But why should we know about retinoblastoma at all? Because it's the most common intraocular malignancy in children. Well, it is. It's a deadly tumor with potential for up to 50% death, but that can be completely reversed with accurate diagnosis and early treatment. It presents to mostly an ophthalmologist first and perhaps to a pediatrician as well. And it is completely curable, as I said, if it is detected early. That's the World Retinoblastoma map. You see that India has one of the highest incidence of retinoblastoma, mainly because of its high live birth rate. India also harbors advanced retinoblastoma, may not be as advanced as other developing countries, but definitely some parts of India are known to harbor advanced retinoblastoma, as has been detected in the CANKID study. We see about 5,000 to 6,000 new cases of retinoblastoma in the world. India does not have hard data, but we estimate that it's about 1,500 to 2,000 new cases that we have in India every year. It may be about 1,500 as per the recent estimates, out of which new retinoblastoma referrals to major referral centers in 2017 was 600. Currently, it is about 1,000. These include medical colleges, if we consider them as tertiary care centers. About 70% of retinoblastoma in India still undergo treatment at primary and secondary levels of healthcare without protocol-based management or no treatment at all. So with about 30 to 50% estimated mortality, and that generally happens without protocol-based management. But if we were to change that management to protocol-based management, which is simple, straightforward, and economical, then we can reduce mortality from 30 to 50% to less than 5%. And that's exactly shown in this slide. The evolution has been very dramatic. In the last 125 years, we have seen that the mortality of retinoblastoma has totally reversed from 98% mortality to 98% survival. That really hasn't happened for any other malignancy except retinoblastoma, mainly because retinoblastoma is work in progress and we are very amenable to adapting new technologies or new trends in the management of retinoblastoma. We learn from our colleagues and we use these new knowledge for the advantage of our patients. And because of that, and because of protocol-based management, early diagnosis, everything put together, we have more than 98% survival in the best of centers in the world. Retinoblastoma Awareness Week, as is observed this week, is key to early diagnosis. This week is utilized for popularizing the signs and symptoms of retinoblastoma among parents and pediatricians so that they know how to diagnose early retinoblastoma and also bring in children who have or suspected to have retinoblastoma. Clinical manifestations are very straightforward and striking. In fact, these children are looking at you begging for a diagnosis. There's stark clinical manifestations. Leukocoria, nobody can miss leukocoria. It's visible externally, and these eyes, if they don't have good vision, the pupil is automatically dilated and the leukocoria shines through. Especially if you're taking a flash photograph or even in daylight, it shines through. Pediatricians can notice this, obviously, by distant direct ophthalmoscopy. Parents can notice it if it's little advanced retinoblastoma. Either a macular tumor, a small macular tumor can have leukocoria, or if it's not a macular tumor to begin with, then the tumor must be filling at least about 40 to 50% of the eye before the child has leukocoria. So it may be an early sign or a symptom in a macular tumor or a late manifestation in a non-macular or extramacular tumor. So it's the most common symptom and sign as well. Leukocoria unilateral or bilateral. Now comes squint. Squint is seen in about a quarter of patients. And squint again is a very striking external manifestation. You really don't have to have equipment to look into the eye. Any child with squint has to undergo a fundus evaluation. Otherwise, we're going to miss that lurking retinoblastoma. They may present with esotropia or exotropia depending on the location of the tumor and the time of onset. But irrespective of that, esotropia is more common than exotropia in retinoblastoma, and you must do a fundus evaluation in every child with strabismus. Reduced vision is a late manifestation, specifically in unilateral retinoblastoma. But if a child has bilateral macular retinoblastoma, then visual inattention is a symptom, or not looking at the mother's face, or not looking at targets, or not looking at bright toys would be a symptom that many patients can come with, especially if the tumor is bilateral. Otherwise, unilateral retinoblastoma, obviously, vision is not a particular concern in terms of parents, because they would notice that the child is normal and active with vision in the other eye. So they may not notice that the child is visually handicapped in the affected eye. Advanced tumors present with redness. Redness mainly indicates that the child may have glaucoma, neovascular glaucoma, or secondary glaucoma, or may have inflammation related to sterile necrosis of the tumor, or sometimes even extraocular extension. So if a child has redness, that means that the child already has advanced retinoblastoma. Fortunately, proptosis because of extraocular extension or orbital extension has become rare, and fungating mass has become extremely rare. That's mainly because of increasing awareness. Now, about the masquerades of retinoblastoma, white eye hypopyon simulating uveitis is often missed. Any child with white eye hypopyon where there is no circumscribed corneal congestion and there is white hypopyon, which may have a level or which may simply have balls of tumor cells in the anterior chamber, you should suspect retinoblastoma. In fact, that would be the first diagnosis and not uveitis. In fact, many of these older children with atypical manifestation of retinoblastoma are treated as uveitis and sometimes even undergo vitrectomy for suspected endogenous endophthalmitis before they are sent for referral. Now, if a child has unilateral or bilateral buophthalmos, that is typically taken as congenital glaucoma. But then, if the cornea is not clear, you may miss the retinoblastoma in the eye. So you may not be able to do a fundus evaluation if the cornea is not clear. So ultrasound B scan is mandatory. Ultrasound B scan and UBM are mandatory in every child with presumed congenital glaucoma before surgery is undertaken. Otherwise, you're going to miss the lurking retinoblastoma. Any child with eyelid edema simulating orbital cellulitis again has to undergo imaging. If it is preseptal cellulitis, obviously CT or MRI may not be indicated, but at least an ultrasound B scan and a good attempt to look at the fundus is necessary in a child with eyelid edema, preseptal cellulitis, or orbital cellulitis. This is frank orbital cellulitis, sterile orbital cellulitis, not because of extraocular extension that the child has this kind of a proptosis, but mainly because of sterile orbital cellulitis because of a necrotic tumor. In fact, the size of the eye is also larger. The child has ophthalmus. In addition, there is tumor necrosis. Retinoblastoma is a round cell tumor. It grows so rapidly that it outgrows its blood supply, resulting in sterile inflammation because of tumor necrosis. That ultimately results in a thysis bulbi. So spontaneous thysis is known in retinoblastoma. Long-standing inflammation in the eye because of tumor necrosis can ultimately result in thysis. If a child were to come to you with thysis bulbi with insignificant history of trauma, or maybe even a significant history of trauma, you should not presume that it is thysis because of trauma or infection, etc. You should always do an ultrasound B scan to start with, and if you're not convinced, you should do a CT scan. And on CT scan, the kind of calcification that you find in a thysical eye because of retinoblastoma would be intraocular calcification. But if it's a thysical eye with secondary calcification, then you would see a sclerochoroidal calcification. So peripheral rim of calcification is more typical of dystrophic calcification, whereas intraocular or calcification within the vitreous cavity is indicative of retinoblastoma. So that's how you differentiate a thysical eye from an eye harboring retinoblastoma. This child came with a history of trauma, and she has had trauma. You can see even a lid laceration that she has, and she has full chamber hyphema. This child unfortunately underwent hyphema drainage by a glaucoma specialist, and 6 months later, she presented with an extraocular tumor, regional lymph node metastasis, and intracranial extension. So this hyphema was possibly resulted in minor trauma to the eye. And the eye was predisposed to have bleeding because it already had retinoblastoma. So it was mistaken to be a case of traumatic hyphema, and no imaging or inadequate imaging was performed here before an intraocular surgery. So every child with hyphema, even if there is a corroborating evidence of trauma, should undergo an imaging, at least an ultrasound B scan, a good one, before you undertake any intraocular surgery. Patients of this sort need clearly to be investigated. This is a child who presented with vitreous hemorrhage, traumatic vitreous hemorrhage, so to say. But you see, look at the blood vessels, they're dilated. Blood vessels are not supposed to be dilated if the vitreous hemorrhage, the etiology of vitreous hemorrhage is trauma. You can also see some kind of a whitish opacity in the mid-periphery. This child underwent vitrectomy by a retina specialist. The child unfortunately developed rhegmatogenous retinal detachment, and you can see the buccal indent, and on top of the buccal indent, the retina specialist noted that there is a creamy white placoid lesion. Now, even posterior to the buccal, that creamy white lurking placoid lesion has gone in. So earlier it was here. Now progressively it has moved posteriorly. So is this retinoblastoma? Of course it is. In older children, retinoblastoma happens in the periphery. Retinoblastoma typically in a newborn were to have a retinoblastoma, it would be in the macula fovea. About 3 to 6 months of age, it would be slightly between the optic disc and the macula, or optic disc or the macula and the arcade. And at about 6 months, it would be right at the arcade. 6 to 9 months, it may be anterior to the arcade, and then towards the equator, and finally in the periphery. So in an older child with retinoblastoma, generally it starts in the periphery and it moves posteriorly as well as anteriorly. That is the reason why these children tend to have ciliary body in affection and hypopion, and they also tend to have a tumor which is quite flat and placoid. So this is the same child that I showed you. You can see now after 6 months of various retinal interventions, the child has a lesion that has progressed posteriorly, and when we enucleated this eye, there is no obvious tumor that is seen. You can see that the retina, it's a normal retina. Retina is just thickened maybe 3 times the normal retina, and that is all the child had. But of course, it was evidently retinoblastoma. So older children with retinoblastoma don't have the classic tumor that you're very accustomed to see, but instead they have thickening of the retina with a placoid mass perhaps, and these tend to be acalcific. So even when you do ultrasound B scan, you may not find calcification in an older child with retinoblastoma, and that is how they are missed. So in this child, there was even iris infiltration. That same child and you can see all the classic manifestations of retinoblastoma on histopathology. So these were some of the masquerades of retinoblastoma. Now, why is it important to know? Because if you don't know about this, you may end up doing something which may harm the child ultimately. This was a child with hypopyon. Again, somebody thought it is pars planitis, and that's the Ozurdex implant that is sitting. So obviously, intraocular manipulation has been done, and this retinoblastoma can now become extraocular. So careful evaluation and appropriate investigations help differentiate retinoblastoma from simulating condition if it's a masquerade. Intraocular retinoblastoma has four distinct subtypes. Endophytic, when the tumor grows into the vitreous cavity, and that has vitreous seeds typically. Exophytic is when you find exudative retinal detachment and intraretinal and subretinal seeds. And the one which you saw in this child is diffuse infiltrative. And of course, there's a bit of this and bit of that, and it's mixed configuration. Endophytic is most common, or some situations, even a mixed configuration may be most common. Exophytic is second more common, and diffuse infiltrative is extremely rare. About the diagnosis, all that you need is a good examination under anesthesia. That is most important. And a good examination under anesthesia should also include baseline tests. If a child has clinical risk factors such as high intraocular pressure, secondary glaucoma, neovascularization of the iris, tumor beyond the ora serrata, getting into the area of ciliary body, where the optic nerve is not seen at all, tumor covering the optic nerve, any group 5 tumor should undergo a baseline CSF analysis and bone marrow biopsy. On top of that, if you find that the patient may have ciliary body affection, or any child with anterior chamber seeds must undergo UBM. OCT is not mandatory, but if you have access to anterior segment OCT under GA, you can use it to determine the extent of seeding in the posterior chamber. You can also use OCT for detection of early retinal tumor. MRI or CT scan are required in certain specific situations. CT scan is advocated only in patients where you want to rule out intraocular calcification. MRI is not a good tool for intraocular calcification. So in a simulating condition, if you want to rule out retinoblastoma, if the media were to be opaque, as you see here, there is cataract, then you would do a CT scan. Otherwise, CT scan gives some amount of radiation to the child and may render the child susceptible to a second malignant neoplasm. So radiation, because of the risk of radiation, CT scan is relatively contraindicated, but MRI is required. MRI currently we use as a very specific baseline tool, mainly to detect if the child were to have an optic nerve extension, which you can't see otherwise. And in the absence of proptosis, you don't even suspect that. And also a small tumor like this can have a massive choroidal invasion. So what does it mean to us? If a child were to have massive choroidal invasion, a small tumor, you will not do intra-arterial chemotherapy. Although there are advocates of doing intra-arterial chemotherapy, despite having choroidal invasion, you wouldn't want to do it because choroidal invasion is considered a high risk feature, and any child with high risk feature would have possibility of microscopic metastasis. And if you are not to give systemic chemotherapy, then the chance of the child having systemic metastasis may become real. But if you were to give intra-arterial chemotherapy, then the systemic concentration of the drug is not enough to take care of microscopic metastasis. So it is relatively contraindicated. So you should do an MRI in every child with retinoblastoma. Now, there are situations where a tumor may look like retinoblastoma, but may not be retinoblastoma, and that is retinocytoma, a translucent tumor with retinal pigment epithelial atrophy located generally in the posterior pole or posterior to the equator. As you see here with intralesional calcification, a lot of RPE changes is a typical retinocytoma. It may even have retinoschisis in long-standing lesions. This was an older patient with retinocytoma, with an older child who's asymptomatic, may have come for screening or may have been incidentally detected extramacular or macular translucent relatively avascular tumor without SRF, with retinal chorioretinal atrophy and RPE changes. Then you suspect that it is retinocytoma. Now, lesions simulating retinoblastoma, the most common conditions are Coats disease, PHPV, toxocariasis, astrocytic hematoma, and medulloepithelioma. Coats disease is very striking. In fact, you don't call it leukocoria, you call it xanthocoria. Leukocoria is whitish, yellowish white reflex, whereas xantho is yellow or golden yellow reflex. Coats disease is amenable to diagnosing just by observing, carefully observing the quality of the reflex. If it is a tinge of yellow or golden yellow, then you suspect that the child may have Coats disease. When you do fundus evaluation, you find typical peripheral retinal telangiectasia and intra and subretinal exudation. Of course, they may be and will be retinal detachment. So the quality of the reflex is totally different in Coats disease as opposed to retinoblastoma, and that's something that is a teaching point. Coats disease will also have peripheral retinal telangiectasia. As I said, in retinoblastoma, the blood vessels are dilated, but they dip into the tumor never to emerge back. Whereas Coats disease, you don't find that. You find segmental dilatation of the blood vessels with telangiectasia at the termination of the blood vessels. Coats disease may also have a macular lesion, but that is nothing but exudates, a collection of exudates. Sometimes it may be even nodular collection of exudates in the macular lesion. You may confuse that with retinoblastoma, but the disease would be lying in the periphery. So you don't find much of vascular changes in the posterior pole, but that's just a passive exudation. Whereas in retinoblastoma, you find the disease itself in the macula. And on ultrasound B scan, it is very characteristic. In Coats disease, you find thickened detached retina, whereas in retinoblastoma, you obviously find the tumor with intralesional calcification. And if you still have any doubt at all, then fluorescein angiography will settle the issue. So you can very clearly see that both these are cases of Coats disease. Whereas this, if you just look at this particular area, then you may feel that it is retinoblastoma. But when you look at the entire retina, you find that there are features of classic features of Coats disease. But there are situations where uh, where a case of Coats disease may mimic retinoblastoma, and a case of retinoblastoma may mimic Coats disease, and vice. So it is very important for us to look at atypical features such as these dilated blood vessels and do a B scan to see if there is any mass at all. And if you have any doubt at all, do an MRI and rule out that there is no retinoblastoma before you decide to observe these patients or do any intraocular intervention. Very striking Coats disease. So the next disease that is a mimic is PHPV. It's present at birth and there is relative microphthalmos. Even if there is a half a millimeter or a 1 millimeter difference in the corneal diameter in the affected eye, you suspect that the patient may have PHPV. And in addition, there's prominent ciliary processes. And if this is the lens, the posterior aspect of the lens, sometimes it is eccentric. You find a fibrovascular band that is getting attached to the posterior aspect of the lens, and that would generally emanate from the optic disc. So this completes the picture of a PHPV. Cataract obviously is present in PHPV. And when you do ultrasonography, again, you find that there is a bullous retinal detachment with a fibrovascular band that is getting attached to the posterior aspect of the lens in PHPV, whereas in retinoblastoma, that doesn't happen. That's a classic clinical appearance fundus picture of PHPV. Now, FEVR can also mimic retinoblastoma, but that is very evident on clinical evaluation. And if at all you have any doubt, you can do FFA under general anesthesia, which is possible with red cap. Toxocariasis can happen anteriorly as well as posteriorly. Anteriorly located toxocara granuloma, of course, there will be intralesional calcification, but there is always a tractional fold. Desmoplasia is characteristic of toxocariasis. That's how you differentiate it from retinoblastoma, despite the presence of intralesional intraocular calcification. A posterior toxocaria granuloma produces drag disc appearance. Again, very typical desmoplastic activity, whereas in retinoblastoma, you don't find desmoplasia, and very rarely do we find it. Retinal astrocytic hamartoma can be non-calcified or calcified. It can also be endophytic and exophytic. In a non-calcified retinal astrocytic hamartoma, you should always look for features of tuberous sclerosis, which may not be present in a young child. Systemic manifestations may appear later. Of course, you can do genetic tests, but then in the absence of all that, clinically, you find a non-calcified retinal astrocytic hamartoma. It's like a button sitting on the retina, obscuring the retinal blood vessels. You don't see retinal blood vessels through it. And a calcified astrocytic hematoma has this fish egg kind of an appearance. Globules of translucent areas of calcification all collected together. That's very typical of astrocytic hematoma. See this. This is what I meant. Globules of calcification with internal translucency. That is very typical of astrocytoma. Whereas in retinoblastoma, you find dense calcification. That is how you differentiate. In astrocytoma, again, the blood vessels don't cross the tumor but go around it. That's very typical. Splaying of the blood vessels around a particular tumor indicate this may actually be very confusing. You may think that it's an early retinoblastoma, but look at the way the blood vessel is circumventing the tumor, going around it rather than crossing it or feeding it. So it's very typical of astrocytoma again. The next disease is medulloepithelioma. Medulloepithelioma is a tumor of the ciliary body. So you find that the zonules are missing. This is what is called zonular coloboma. You can also call it lens coloboma in the area where the tumor is located. Because it's an embryonic tumor, zonules don't develop at all, resulting in a lens notch or what looks like subluxation. But there is a peripheral ciliary body tumor that you see here, whereas in retinoblastoma, that doesn't happen. And of course, in medulloepithelioma, you find hyaline cartilage within the tumor with calcification. So you always have intraocular calcification in medulloepithelioma, teratoid, or sometimes it may be missing in non-teratoid, but that doesn't make it retinoblastoma because of its location and also its nature of very slow growing, being very slow growing unless it is a malignant tumor. Now, endogenous endophthalmitis can also mimic retinoblastoma. This is a child with endogenous endophthalmitis. Sometimes it's very difficult to differentiate it from a necrotic retinoblastoma. So you should take the help of a CT scan to see if there is an intralesional calcification or MRI, and not jump in to do a vitrectomy in a child with what looks like endogenous endophthalmitis. That, of course, this glow that is seen, the white reflex, is very significant. Along with that, the child had a history of leukocoria for a long time. And finally, the tumor became necrotic, and that looked like endogenous endophthalmitis. Of course, you find intralesional calcification here, which is very characteristic of retinoblastoma. Fungal endophthalmitis can also be a close mimic. This was a long-standing fungal endophthalmitis in a of course, it was endogenous fungal endophthalmitis. Child has had urinary catheterization long time ago, and this perhaps lingered on for a while because the child obviously was immunocompetent and that looked like vitreous seeds. So careful evaluation again and appropriate investigations help differentiate retinoblastoma from a simulating conditions. The reason is that you should not start on chemotherapy or enucleate an eye in a non-retinoblastoma condition without confirming with the best possible efforts that it is not retinoblastoma or it is retinoblastoma. Otherwise, you may end up having enucleating or starting chemotherapy in an eye without retinoblastoma without much ground. Now going on to classification. This is discarded. So in 1963, which is only for historic importance, Rees-Ellsworth classification was described, and 1981 SN classification was described. These at that time were good classifications. At that time, radiation was the treatment of choice. So these predicted the efficacy of radiation. So whenever you have a classification, it has to follow the logical sequence of the disease, which it should anyway. It should be simple and easy to recall. Rees-Ellsworth is a very complicated classification. And most important is that it should be applicable to current therapeutic modalities. Otherwise, why do you want to classify? You know the features of the tumor, you know how advanced it is. Classification is mainly to prognosticate and tell the parents that your child has so much chance, 60 to 80% chance of eye salvage or 100% chance of life salvage. All this is possible by applying classification. Now, classification has two parts. One is staging, where survival of the patient is the outcome, and grouping, where eye salvage is the outcome. So you should stage as well as group a child with retinoblastoma. Now, staging is very simple. This is International Retinoblastoma Staging System. Stage 0 is conservatively managed child, no enucleation. So this has the best prognosis. Then stage 1 is enucleation has been performed and the tumor is completely resected. Completely resected, pathologist has to tell you so. You should have a good pathology backup to manage retinoblastoma. Stage 2 is enucleation with microscopic residual, which means that the pathologist has reported either full thickness scleral invasion, extraocular tumor cells, or optic nerve invasion to the level of transection, or even skip lesions with the optic nerve sheath. Stage 3 is regional extension. Orbital and regional lymph node extension is stage 3. And stage 4, of course, is metastatic disease. And between stage 3 and 4 is the watershed zone. Until stage 3, you have about 90% life salvage. Beyond that, you have less than 5% life salvage. So staging is extremely important. Now, international grouping of intraocular retinoblastoma is a very easy grouping system, A to E, in terms of severity. Any child who has a tumor which is less than 3 millimeter, extramacular is A, group A. B is for bigger tumors, more than 3 millimeter, macular in location, close to the fovea, less than 3 millimeter, close to the optic disc, less than 1.5 millimeter, is group B. Group B also has subretinal fluid. So group B is a bigger tumor, B for big. C is for confined or contained subretinal seeds or vitreous seeds. If it is exophytic retinoblastoma, you find subretinal seeds. If it's endophytic retinoblastoma, you find vitreous seeds. So vitreous seeds and subretinal seeds very close to the tumor itself is group C. D is for diffuse. Any child with diffuse subretinal or diffuse vitreous seeds is group D. And now E is very controversial. E is a mixed bag. There is a lot of controversy about group E, and international grouping of intraocular retinoblastoma does not do justice to group E. And unfortunately, in developing countries, we have group E predominating. 80% of our children in developing countries have group E retinoblastoma, and it's very important that we subcategorize group E into identifiable subcategories which have prognostic implications and triage them for appropriate treatment. So we have, for group E patients, definitely have to take the help of TNM classification. Now, TNM is very logical for group E. You can see that advanced intraocular tumors, group E, it's not flowing. I would put phthisis perhaps if I had a chance to revise it last, because these tumors with invasion of the anterior chamber have the best prognosis. These are depository anterior chamber seeds. They can easily be saved. So they should come somewhere as T3A. And then the infiltrative anterior chamber seeds, which are salvageable, but slightly more difficult and have a less poor prognosis, can come as 3B. Phthisis and prethysical eyes are generally not salvageable. They have to undergo enucleation, and they have histopathological risk factors, increasing their chance of mortality. So anyway, but TNM classification gives us a better handle on group E retinoblastoma, and we should try to use that in our management. Going on to management itself, goals of management would be life salvage as the primary goal, organ salvage as the secondary goal, vision salvage as the tertiary goal. You should never reverse the goal. If life salvage is possible, then you optimize eye salvage with whatever modalities that you have at your command. And if eye salvage is possible, then you try to optimize vision with whatever modalities that you can garner. So there are many treatment modalities in retinoblastoma, and you have to use these judiciously. In a group A tumor, less than 3 millimeter, confined to the retina, distant from the optic disc, distant from the fovea, you really don't have to worry about life salvage, especially if it is unilateral. Even if it is bilateral, life salvage is guaranteed. Eye salvage is guaranteed. So what are you supposed to do here? You are supposed to conserve vision by doing focal therapy. And the challenge is to produce minimal scarring and minimal collateral damage. And the aim is to provide maximum possible vision and visual field to these children. Cryotherapy is used for small peripheral tumors, which is a very good modality. It has 90% success. Success-wise, there is no problem with cryotherapy. But the problem with cryotherapy lies in the fact that it is a very extensive treatment, in the sense that the tumor is elevated on the tip of a 3 or 4 millimeter cryoprobe. That is the tumor that is elevated. And when you freeze it, not just the tumor, but the retina around it also gets frozen. And cryo is very heavy. That's the tumor, and the end point is freezing of the vitreous anterior to it. So that makes the scar much larger than the tumor that you began with, which is okay if the tumor were to be on the nasal periphery. But what about temporal mid periphery? Somewhere anterior to the equator. If you freeze it stiff like this, then the child has a higher chance of having, let's say, epiretinal membrane, distortion of the macular fovea, and also multiple attempts at cryotherapy will make create a situation where there is a high risk of rhegmatogenous retinal detachment because of atrophic retinal holes. So cryotherapy is good, but it is not ideal in many situations, mainly because of the scar size and the complications. Photocoagulation is mentioned only to be condemned. It is not to be done in retinoblastoma because of the large scar that it produces. The principle of photocoagulation is to anemize or cut off the blood supply to the tumor. And you do it by lasering around the tumor. Not one row, but two rows of lasers. Look at the scar that is going to be now. So if you have a tumor that's so small to begin with, you're ending up producing that larger scar. And the blood vessel that pass through that area will obviously get coagulated. If you were to laser on top of a tumor, then you'll break the internal limiting membrane and you have a risk of producing vitreous seeds. So laser photocoagulation should not be done on top of tumor. It has to be done around it. And there is a much larger scar with vascular occlusion and the risk of visual field defect. If this is a child with superior juxtapapillary tumor, if you photocoagulate, the child will end up having a severe inferior arcade scotoma. ILM rupture, as I said, and it also reduces chemotherapy uptake because you are obscuring or occluding the blood vessels. So this is not to be done. So what is to be done is transpupillary thermotherapy, 60 to 65 degrees centigrade to render it gently white. So slight change in color is your endpoint. You always do on top of the tumor. Don't go beyond the tumor. And you end up having a nice crisp scar like this and patent blood vessels. Small blood vessels also remain patent. So visual morbidity is much less, whether you're talking about Group A or Group B retinoblastoma, however close to the disc or macula it may be, TTT is the safest if you were to treat it. So for focal therapy, the standard of care currently is transpupillary thermotherapy, and lower the power, the better. You don't have to go to 500 or 800 setting. You can start with very gentle 300 or 200 and see how it works. And you'll always have a second chance to do more of it. You don't have to actually do everything at the first session itself. 6 weeks later, you call the child back, see how is the response, and you add more of TD to it. But the idea is to get a crisp scar like this without any retinal pigment epithelial changes. So if you have a tumor like this, you only do TTT to the tumor and not overlap spots to the edges at the first session itself, because that will result in a large scar and retinal pigment epithelial atrophy or hypertrophy. So limit TTT to the tumor and not go beyond it. Recent advance in TTT is ICG enhanced TTT. This is synergistic. I don't have time to discuss the principle, etc. But basically, when you combine ICG and TTT, you can treat tumors which are on top of a amelanotic scar. So this was a child who had a regressed retinoblastoma, and between the scar and the optic disc developed a recurrence, and that was easily treated with transpupillary thermotherapy. So this was a child, again, you see that there is this small recurrence at the edge treated with transpupillary thermotherapy. So in focal therapy, less is more. TTT has taken over. Photodynamic TTT is good for tumors on a non-pigmented scar or a refractory to TTT. So in group B tumors, which are much bigger, located in the macular area or foveal area with or without subretinal fluid, or group C with focal subretinal seeds and focal vitreous seeds, or group D with diffuse subretinal seeds or diffuse vitreous seeds, much larger tumor, or group E tumors occupying more than 50% of the globe volume, we have to start on systemic therapy. Why? Because we want eye salvage, we want life salvage, we also want much better vision. That is the reason why chemotherapy has become uh, the standard of care in the management of group B to E retinoblastoma. B, you cannot easily do focal therapy. So you have to, unless you want to, you have no regard for vision, of course, you can do focal therapy in group B. But if you want to have regard for vision and you want to maximize visual potential, then you have to resort to systemic therapy. November 1996, 30 years ago, everything changed. Archives of Ophthalmology, now JAMA Ophthalmology, published a series of 4 groundbreaking articles, all on a new modality in the management of retinoblastoma, that is chemotherapy, systemic chemotherapy in the management of retinoblastoma. At that time, it was called chemoreduction. This is a form of neoadjuvant chemotherapy. That is all it is. So neoadjuvant chemotherapy takes you back in time, because if you have a tumor that's 12 millimeter or 18 millimeter in size, it makes it 6 or 10, 8 millimeter in size before you start your focal therapy. So it is taking you back in time. It brought about a paradigm change in the management of retinoblastoma by reducing the tumor size so that focal therapy is possible. It uses simple drugs, carboplatin, etoposide, and vincristine. All are time-tested drugs. Toxicity profile is known. Cumulative dose toxicity is known. 3 to 4 weekly cycle, 6 cycle standard. EUA must be performed before each cycle. Ocular oncologist or the treating ophthalmologist has to rule the treatment, not the oncologist, because you have to do EUA before each cycle. Provide chemocryotherapy to enhance intravitreal concentration. That's because when you do chemocryotherapy, you break the blood retinal barrier and increase the intravitreal concentration of chemotherapy. You can also start focal therapy from cycle 4 onwards, because focal therapy in terms of TTT to the tumor makes it chemothermotherapy or thermochemotherapy, depending on which sequence you do it. And that actually is beneficial. If you do chemotherapy and thermotherapy on the same day within a few hours, whichever happens first, irrespective of that, you call it chemothermotherapy or thermochemotherapy, depending on the sequence, it makes the tumor respond better. So you have to do all this in each EUA. How does chemotherapy work? Whether it is intraarterial or intravenous, chemotherapy works by 3 simple mechanisms. One, of course, is it reduces the size of the tumor that we know. The second, as you see here, this is the size that we began with, and we have ended up a much smaller size. That's one, clearly. The second is that tumor always hangs on to its source of blood supply. And whenever we are concerned about vision, it is the posterior polar tumor that you're talking about. And posterior polar tumors derive blood supply from either supratemporal, infratemporal, supranasal, or infranasal arcades. Correct. Now, when the tumor hangs on to its source of blood supply, it regresses away from the macular fovea, especially if it is from the supratemporal or the infratemporal arcade that it is deriving the blood supply from. For example, this is a tumor which is deriving blood supply from the supratemporal arcade. So after 1 cycle of chemotherapy, see, this is the presentation, it is abutting the fovea. After 1 cycle, it has moved away slightly. After 3 cycles, the fovea macula is absolutely fine. Clinically looks normal. And the tumor has moved away towards its source of blood supply, and the caliber of the supratemporal arcade has also come down. So tumor hangs on to its source of blood supply, moves away from fovea macula with each cycle of chemotherapy. That's a major advantage for the child, because the area of central vision is getting exposed. One more example, macula completely occupied after completion of chemotherapy, very healthy fovea. Shrinks the tumor, regresses towards its source of vascularity, and exudative retinal detachment settles down very early in the course of treatment. And that is how intravenous and also intraarterial chemotherapy work. It was the standard of care in early 2000s. It is still the standard of care in developing countries. It is still the standard of care in India for obvious reasons. Cost, it is cost effective. It can be given in ophthalmology centers. The family need not go to an oncology center. Oncologist can come to an ophthalmology center and give intravenous chemotherapy by a trained nurse. It can be given. So it is very popular and it is cost effective. We began with standard intravenous chemotherapy. Now we have all these forms of chemotherapy. We have intraarterial, we have periocular, and we have intraocular, and I'll discuss all that. Mentioned only in passing, mainly because it was a fad at a particular point in time where intraarterial chemotherapy was not accessible in India. So at that point in time, we came up with high-dose intravenous chemotherapy for specific tumors such as bad group E situations. This was a patient that was treated with high-dose intravenous chemotherapy and he did well. It's mainly used for currently for orbital retinoblastoma, but not for intraocular retinoblastoma. It's relatively more effective than standard dose for group D and E. That was the conclusion at that time. Now, of course, we have intraarterial chemotherapy, which is the current standard of care world over. So if somebody asks you what is the standard of care for groups B, C, D, E retinoblastoma, the answer is intraarterial chemotherapy. But having said that, the prognosis in terms of eye salvage or vision salvage does not change for group B and C, irrespective of whether you give intravenous or intraarterial chemotherapy. Eye salvage, vision salvage remains the same for B and C. It's for D and E that intraarterial chemotherapy has an advantage. For D, maybe about 10%. For E, maybe about 15% increased eye salvage over intravenous chemotherapy with intraarterial chemotherapy. Additionally, systemic toxicity is negligible with intraarterial chemotherapy. Of course, the child will have some radiation exposure because of the nature of performance of intraarterial chemotherapy, and that is found to be insignificant. Of course, we don't have very long-term data. The oldest child who was treated with intraarterial chemotherapy is only 20 years old now, so there might still be a chance of systemic radiation-induced systemic malignancies that may come up in the future. But currently, there is no evidence that intraarterial chemotherapy has a higher risk of radiation-induced second malignant neoplasm. But in any case, for group D and D, it matters. And when we use intraarterial chemotherapy, we use 3 drugs. The drug of choice, if you were to use one drug, is melphalan. Of course, you add topotecan and carboplatin to increase the efficacy, and we use this as the standard of care because we want to minimize the number of cycles of intraarterial chemotherapy to 3 or around that. So we use 3 drugs. Otherwise, some of the centers use melphalan as a single drug, or 2-drug chemotherapy is also used. If you give bilateral intraarterial chemotherapy, then to reduce the toxicity of melphalan, you use it in one eye, the worse eye, and in the other eye, you don't use melphalan, you use topotecan and carboplatin. So that's some of the adjustments have been made in the protocol by different centers. Now, intraarterial chemotherapy involves an interventional neuroradiologist because he or she has to get us access to the ophthalmic artery. After that, the drugs are injected under monitoring, and the results are very dramatic. As you see here, this large tumor finally goes away and reduces to a much smaller scar. So intraarterial chemotherapy works faster and more intensely than intravenous chemotherapy for group D and E retinoblastoma. These are all pre and post intraarterial chemotherapy. You can obviously see the results. They're all very good. Optic nerve is exposed, macula is exposed, child has regressed tumor and a good visual potential. Total retinal detachment, bullous retinal detachment completely gone, and a calcified tumor. Similar example here. So intraarterial chemotherapy is extremely good, and that is the reason why it has become the standard of care. It works well for tumors which are recurrent. So this was a child who had a recurrent tumor following intravenous chemotherapy, and with intraarterial, it's gone. Of course, alternative would have been plaque brachytherapy. Now, what about the technique itself? Technique is extremely standardized. In the last 100 consecutive sessions, 98% was the cannulation rate, only 2 were balloon, and the cost is only the barrier. So we have the technology, we have the expertise. Cost is the barrier for practicing intraarterial chemotherapy routinely in India. Okay, now some examples of group B tumors. This was a child with bilateral group B macular tumor treated with intravenous chemotherapy. Alternative could have been bilateral intraarterial chemotherapy. But the child being small, 4-month-old, you don't want to risk long GA and also bilateral intraarterial chemotherapy. So intravenous chemotherapy is a good option. This was a child, 1-year-old child with group B in the right eye, treated with intraarterial chemotherapy, 3 cycles, without any consolidation. So there is a controversy about consolidating macular tumors following intravenous or intraarterial chemotherapy. Some patients where there is no evident residual tumor, you don't want to consolidate and risk vision. The risk of not consolidating is that these children tend to have about 25 to 30% recurrence if you don't consolidate at all. But if you were to partially consolidate is extramacular focal therapy, not towards the macular fovea, but if the tumor edge is away from the macular fovea, that you consolidate and leave the macular component or foveal component unconsolidated, chance of focal tumor recurrence is slightly lower, about 15 to 20%. But if you consolidate, if you treat the entire residual tumor or residual scar to make it absolutely flat or clinically regress, then you have a very low chance of local tumor recurrence, less than 5%. So this was a patient where you see that intravenous chemotherapy has been given and the tumor is regressed. And this particular area where you see some amount of yellowness, that's the foveal region. So we left it unconsolidated and you can see a recurrence here, right? You see a recurrence right there. So there is a higher recurrence when treated with chemotherapy alone, irrespective of whether it is intraarterial or intravenous. So you should be very judicious in consolidating, I agree. But at the same time, if you haven't consolidated, you should keep these children under very close follow-up because they have a higher chance of local tumor recurrence. Now, this was a patient where, of course, intravenous chemotherapy was given. You can see that the tumor regressed and there is a recurrence, that is poor response to TTT, and that settled with ICG enhanced transpupillary thermotherapy. So in this patient, again, extramacular component has been consolidated. Now, about macular tumor without cysts, with cysts need obviously more care than macular tumor with cysts. So this was a macular tumor, and after intravenous chemotherapy, the cystic component is residual with atrophic retina, then you don't have to further consolidate. Macular tumors with cysts may not need consolidation. So that is the dictum. But then if there is a solid element in a macular tumor, that needs further treatment. This is an example, which is a very beautiful example, where you see that this is the tumor that we began with. After intraarterial chemotherapy, this portion has become quite cystic, but there is still a solid component. The option was to leave it alone without consolidation, without further treatment. But because of the solid component, we opted for intravenous chemotherapy. Then you find that the entire tumor has become cystic with some amount of calcification. At that point, you can leave it without further consolidation. Suppose I had left it at this point as some of the oncologists advocate, then it would have definitely recurred because obviously this was active tumor and that is the reason why it has responded to further intravenous chemotherapy. In group C tumors and group D tumors and of course group E tumors, chemotherapy works very well. As you see here, this was a child of group C treated with intraarterial chemotherapy, 3 cycles and transpupillary thermotherapy, complete regression of the tumor. Group D tumor treated with intraarterial chemotherapy, 3 cycles and intravitreal topotecan for the vitreous seeds, completely regressed. And a child with group E tumor treated with intravenous chemotherapy and transpupillary thermotherapy, completely regressed. So these examples show you that combination of chemotherapy and focal therapy is very effective. This child has a large tumor which is completely regressed, and you can see nice disc and macula with intravenous chemotherapy and focal therapy. And also you should realize that intravenous chemotherapy may work when intraarterial chemotherapy fails. So this patient had received intraarterial chemotherapy elsewhere, group D retinoblastoma. And that is the picture when the child came with 3 cycles of intraarterial chemotherapy, well performed, technically well performed, appropriate drugs and dosages used, but there was minimal response of the tumor. When we switched this patient to intravenous chemotherapy, after 3 cycles, there was good response. After 6 cycles, there was nearly complete response, and we did TTT sparing the fovea, and the child continued to do well. And vice versa is also true. If a child has intravenous chemotherapy, you can see that intravenous chemotherapy has been given 6 cycles elsewhere, and there are subretinal seeds there. Then we shifted the child to intraarterial chemotherapy. All this residual tumor regressed with intraarterial chemotherapy, and subretinal seeds also went away. So if a child fails intraarterial chemotherapy, you can go for intravenous chemotherapy and vice versa. Now about the vitreous seeds. There are many types of vitreous seeds and the theories are also different. One theory is that there is breach in the internal limiting membrane with growth of the vitreous seeds. These are all work credit to Dr. Munia, who has done phenomenal work in the realm of vitreous seeds. And the second is sprouting of a vitreous seeds from an endophytic tumor. Irrespective of that, they go into two growth patterns. One is adherence independent growth pattern, where the seeds or the cells derive nutrition from the vitreous itself. So they become independent bodies of small uh, uh, collection of cells, or you can call it tumor itself, growing within the vitreous cavity without any substrate or vascularity from a substrate. So they are adherence independent growth pattern, resulting in free floating spheres. The second pattern is adherence dependent growth. So when these cells in the vitreous cavity settle down onto the retina and then proliferate, they form what is called epiretinal seeds. So this is very clear: adherence dependent growth and adherence independent growth. Now, what are the types of retinoblastoma seeds? In fact, we don't call them vitreous seeds at all. This review article you can read if you're more interested in August issue of Survey of Ophthalmology. You can find that we have classified it totally differently. We have classified it as classic vitreous seeds. Then there are prehyaloid, subhyaloid, epiretinal, intraretinal, and subretinal seeds. And intracameral seeds are further classified as depository seeds and infiltrative seeds. Depository seeds are the ones which are nothing but vitreous seeds that have walked through the zonules and come into the anterior chamber. Infiltrative seeds are contiguous infiltration of the ciliary body, anterior chamber angle, and the iris as well. So these are classic vitreous seeds. These are prehyaloid seeds. All these are OCT-based classification. Of course, you can corroborate that clinically as well. Subhyaloid seeds, epiretinal, intraretinal, and subretinal seeds, all in the same eye. Depository anterior chamber seeds without any ciliary body involvement. So the dictum is that whenever you find even a single anterior chamber seed, you should do UBM. UBM for ciliary body involvement, iris involvement, mandatory. You can also do anterior segment OCT if it is accessible to you under general anesthesia, but UBM is 360-degree UBM is mandatory. This is an infiltrative anterior chamber seed with iris and angle invasion. No more thanks to Dr. Munia. Dust, as the name indicates, small little particles, cloud, collection of membranous vitreous seeds clouding the retina. Spheres, as the name indicates, large balls of vitreous seeds. And mixed type is more common. So a bit of this and bit of that is more common than an isolated pure variety of vitreous seeds. How do we treat vitreous seeds? When the retinal tumor is viable, obviously you're going to give intravenous or intraarterial chemotherapy, and you can add periocular chemotherapy as well. This is optional, but we practice it in our setup. So irrespective of the child receiving intravenous or intraarterial chemotherapy, periocular topotecan enhances intravitreal concentration of the drug, and that may provide an additional benefit in early resolution of vitreous seeds. The child may not need intravitreal chemotherapy at all. When the retinal tumor has nearly totally regressed, for the residual vitreous seeds, viable vitreous seeds, intravitreal chemotherapy is ideal. So intravitreal chemotherapy has to be practiced in a safety enhanced atmosphere. You cannot give intravitreal chemotherapy if the retinal tumor is large and active, mainly for the fear of extraocular extension of the tumor. For periocular chemotherapy, which is delivered deep posterior subtenal in the axis away from the extraocular muscles. So if these are the four extraocular muscles, you should go in between the extraocular muscles and deliver it. Preferred site is infratemporal without causing an anterior effusion. Carboplatin used to be used earlier, but produces a lot of scarring. So what is currently used is topotecan for periocular chemotherapy. This was a child in a published article um, of periocular chemotherapy, where you see that just with intravenous chemotherapy and periocular chemotherapy, all the vitreous seeds were regressed. In fact, this was the first child that was treated, otherwise was enucleated. At that time, we did not have intravitreal chemotherapy in vogue, and this child was totally treated with intravenous chemotherapy and periocular carboplatin at that time. And this was published again with 76% eye salvage with carboplatin in eyes with diffuse vitreous seeds. And when with topotecan, we had about 68% complete remission of vitreous seeds. This was a recent article. So irrespective of which drug that you use, periocular chemotherapy actually works, and there is fair amount of evidence to support that. But intravitreal chemotherapy is very powerful. We all realize that. So if, when it is possible, when the intraocular tumor has nearly totally regressed, you have to bring in the big gun, that is intravitreal chemotherapy. What is safety enhancement? Safety enhancement first criteria is that the retinal tumor should not be large. Choose a safe site, at least 3 clock hours away from the main tumor. Exit through eyes. So when you inject, if this is the site of injection, you freeze the hub of the needle and exit through eyes. And on top of that, you do injection site cryotherapy. You can also pool distilled water in the cul-de-sac, that is called death by water, which is generally not done. You can also raise a bleb of subconjunctival topotecan, which is optional. Now, this was the first child that I treated with intravitreal melphalan. 20 micrograms was the dose, worked very well. Second child worked very well. But over a period of time, we started discovering that there's a new complication which was not described in the Western literature so much. Extensive retinal pigment epithelial change, including macular area resulting in loss of vision or suboptimal vision. In addition, melphalan produces uveitis, cataract in pigmented eyes such as ours, Asian Indian eyes. It needs weekly injections or more frequent injections. Multiple injections has retinal toxicity, which has been demonstrated. Topotecan does not have any of these. It has much better bioavailability, fewer injections are required. Lazy 3 weekly or 4 weekly topotecan is just fine, logistically making it convenient for a child who may not be from the same city. And there is hardly any retinal toxicity that has been demonstrated. In the first series that we published, we had 100% success because we selected out only 17 patients very tentatively, whether it will work or not. 30 microgram was the dose that was given. Very happy with the results, and emboldened by that, we started doing it in much severe cases, and the success rate obviously fell because we were selecting out cases which are very difficult. But the long-term results have been published in ophthalmology. You can read it up. Very encouraging results. You're able to save eyes in about 97%. Intravitreal topotecan, earlier we started using 30 microgram 3 to 4 weekly, worked very well for all these tumors. It has worked well. You can see 2 to 3 doses was all that was required. But as the difficulty index increased, when we started treating much worse seeds like this, then we needed more frequent injections or a higher dose. So currently we use a much higher dose. We use 60, 90, some centers use more than 100. We are attempting, some centers are attempting 200. So basically the concentration of intravitreal topotecan is being increased without any additional retinal toxicity. It's very encouraging. At the same time, animal experiments support the use of about 100 microgram. So 100 is maybe the limit or may not be the limit. We really don't know yet. There's always a possibility of increasing the dose and looking for response as well as side effects. Earlier, when a reasonable amount of intravitreal topotecan failed, this was a tumor, that is the bunch of vitreous seeds. After 6 cycles of chemotherapy and periocular topotecan, that is the amount of vitreous seeds that is left. Tumor is regressed. After 6 injections of intravitreal topotecan, seeds are better, but you still see that the seeds have completely regressed, but you can see retinal pigment epithelial atrophy in that area. Now, high-dose intravitreal topotecan is used for cases of this sort, extensive vitreous seeds, where you suspect that the number of injections that you would need would be far too many. But if you use 90 microgram or 60 microgram of intravitreal topotecan, it is more powerful than otherwise. So this is again an example of a cloud of vitreous seeds obscuring the regressed tumor, completely gone with high-dose intravitreal topotecan. Now, what are the regression patterns? When you start doing intravitreal injections, you should also know how the seeds regress. Otherwise, when do you stop? You should know the regression pattern. Complete disappearance, of course, is not controversial. Type 0. Conversion into calcified seeds, type 1A, or crystalline refringent dust is type 1B. Amorphous non-spherical seeds is type 2. Combination of regression pattern is type 3. So if you have a fat round vitreous seed, if it becomes like this, amorphous and calcified, that is regressed. Or if you have a fat round vitreous seed like this and it goes into an eggshell calcification with central transparency, that is also regression. If you have a fat round seed like this, but it becomes a completely calcified sphere, that is also regression. So there are many types of regression pattern which you'll keep identifying. Sometimes you suspect that the seeds are regressed, but they're not actually regressed. So it's a good idea when you find that the vitreous seeds have regressed to top it up with one additional injection of intravitreal chemotherapy. We call it +1. So for example, at the fifth injection, if all the vitreous seeds are seemingly regressed, I would still go ahead and give one more injection at that visit. That is only as a top-up measure. This from the Munier's work, where you find various types of regression patterns. Amorphous seeds, as you see here, very striking. Now, intraocular chemotherapy, extended indications are depository anterior chamber seeds. Obviously, intracameral chemotherapy or intravitreal chemotherapy works very well for these situations. Bicameral chemotherapy has been described, and that also works very well. But you have to do UBM, as I said, and following UBM, you can give intracameral chemotherapy or intravitreal chemotherapy. The choice depends on the extent of the seeds. If there are concurrent vitreous seeds, then you give intravitreal chemotherapy. If there are no concurrent vitreous seeds, only anterior chamber seeds are present, and on UBM you have ruled out that there is no ciliary body affection, then you give intracameral topotecan. Another extended indication is combined vitreous seeds as well as subretinal seeds, completely gone following intravitreal topotecan. This is for diffuse subretinal seeds. Again, you can give intravitreal topotecan. Otherwise, we would have lasered all these areas, resulting in large scar. Now, no longer laser is performed. We gave intravitreal topotecan for endophytic budding. This would have been earlier treated with a reinitiation of chemotherapy or plaque brachytherapy. Now, we simply use intravitreal topotecan for these patients. Multifocal recurrence. Again, earlier we would have started on systemic or intraarterial chemotherapy for this. Now, high dose intravitreal topotecan is all that is required. Recurrence over optic nerve head. You can see optic nerve obscured completely. Following intravitreal topotecan, you can see we can visualize the optic disc again. What is coming? Perhaps chemoplaque, which is a drug delivery system. There are many other forms of drug delivery systems or drug introduction systems that are being explored. One of which yesterday we heard suprachoroidal injection and transscleral delivery systems that are also being explored, and they may come into vogue very soon. In any case, RP seeds are finally conquered. Now, a bit about plaque brachytherapy. Plaque is not generally used as a primary treatment for retinoblastoma because it produces complications such as radiation retinopathy, and the scar size is as large as the tumor itself. So it's used as a secondary treatment for recurrent or residual tumor. But the designs of plaque have improved. So it's a technique that is something that you always keep as a standby. This was a recurrent tumor, very aggressive, where plaque was used. You may be very happy that the tumor is nicely regressed. Well, it is. But if you look at it carefully, you can see that the retinal changes occupy the entire area where there was tumor earlier, and there is also a vascular block. These are imminent complications of plaque brachytherapy. You can't avoid these complications. So if I were to treat this child now, I would have possibly treated with intraarterial chemotherapy. This was in an era where intraarterial chemotherapy was not available, plaque was available. So you would treat IVC recurrences with plaque brachytherapy. So plaque has specific indications. Of course, with the Indian plaque, cost has been reduced, so it's become accessible. EBRT is mentioned only to be condemned. It has much poorer outcome, but the major complications are second malignant neoplasm. If you were to give EBRT to a heritable retinoblastoma patient, 1/3 of them would develop second malignant neoplasm. If you were to give EBRT in a situation where the age is less than 12 months. So EBRT is to be avoided unless it is given for life salvage, such as in orbital retinoblastoma. It's no longer favored. It is to be avoided. Now, about high-risk retinoblastoma, the incidence is very high, especially in low and lower middle and upper middle income countries. 62% is what the global retinoblastoma study found, and extraocular retinoblastoma about 20%. These are very high numbers and obviously of concern. And when you extrapolate that to international staging system of retinoblastoma, you find that as the stage increases, there is worse prognosis. This is linear, absolutely linear. And that is the watershed zone. So between stage 3 and 4, there is a change in prognosis drastically. So this is very important that you have to differentiate good group E from bad group E. Group E is a mixed bag. It has everything. So now you have to see which one is good group E, where there would be response of this sort, and which one is bad group E. What are the bad players? That is why you have to further segregate group E into tangible sub classifications, and TNM actually helps us do that. So let's just go with the TNM without changing it for the sake of convenience. CT3A is thysis bulbi, 3B is anterior segment infiltration, 3C is neovascular glaucoma or glaucoma, 3D is hyphema, and 3 is sterile inflammation. Let's start with thysis. Thysis or prethysis, you have to image before enucleation. Obviously, enucleation is the treatment of choice. Imaging is to be performed mainly because such eyes may harbor an orbital retinoblastoma, especially if the thysical eye and the normal eye are at the same level. You see, this is a thysical eye. You would expect ophthalmos here, but it is absolutely at the same level as the other eye, which means that there is something behind it, and that was a orbital component, orbital retinoblastoma. You cannot venture into enucleating this eye without a MRI scan. Now, optic nerve extension is possible even in a thysical eye. You can see that optic nerve extension is present in a thysical eye, which was enucleated and which was evident on CT scan. 3B is anterior chamber seeds. Here, the role is to subcategorize this into depository anterior chamber seeds and infiltrative anterior chamber seeds. In depository anterior chamber seeds, as I already showed, intracameral or intravitreal topotecan works well. Baseline imaging is mandatory. UBM is mandatory. MRI is mandatory for ciliary body tumor. This child had ciliary body involvement. Obviously, that has to be documented. Of course, this eye could be salvaged. This was a uniocular patient, other eye enucleated. So for the ciliary body component, we could do plaque brachytherapy, and of course, intravenous chemotherapy also helped. And for the anterior chamber seeds and vitreous seeds, we could give intravitreal chemotherapy. For a ciliary body tumor, if it is not visible, you should do MRI scan. Here, well, obviously, it was visible, but you can note the extent of the ciliary body component by doing an MRI scan. This was a patient with both infiltrative anterior chamber seeds and also a ciliary body tumor. You can see the ciliary body tumor right behind and extensive anterior chamber seeds with iris infiltration. But this eye could also be salvaged with high dose intravitreal topotecan after 6 cycles of intravenous chemotherapy and intracameral topotecan as well. So these are rare instances where there is a desperate need to save these eyes because the child may have already lost the other eye. For patients with hyphema and vitreous hemorrhage, you may observe for a reasonable period of time, but that has to be a finite period of time. It cannot be prolonged because these children have a high risk of having histopathological risk factors. And if you prolong your observation, they may end up with systemic metastasis. So at parents' request or your own discretion, you may observe this patient for 6 weeks or 3 months. But after having done an MRI scan to rule out a high risk radiological iris feature, but otherwise primary enucleation is indicated, followed by histopathology guided adjuvant therapy. For 3D neovascularization of the iris, glaucoma, and ophthalmos, these eyes for some peculiar reason can be salvaged. In our study, we found that children less than 6 months did very well, and this child had neovascular glaucoma, and you can see complete tumor regression after treatment. So younger children with elevated intraocular pressure, sectoral neovascularization of the iris, or even diffuse neovascularization of the iris have a much better chance of eye salvage than older children. Older children, if it's unilateral, must be enucleated. CT3E, sterile inflammation. You should not do primary enucleation, mainly because it may bleed a lot, making surgery very difficult, may make a long optic nerve stump very difficult. You should image them first, treat them with steroids, topical and systemic, let the inflammation quieten down, and if required, give neoadjuvant intravenous chemotherapy. And if you start neoadjuvant chemotherapy, it has to be given for 6 cycles. If you give only for 2 or 3 cycles and find the eye thiazical and enucleate and on histopathology, you don't find histopathological risk factors, you may stop chemotherapy at that point in time. But that is not correct because microscopic metastasis may already be there. This has been very nicely shown in the Chinese study where they stopped intravenous chemotherapy 2 or 3 cycles and they found a higher rate of systemic metastasis, obviously because it was not completed. So whenever you venture neoadjuvant chemotherapy, it has to be given for a mandatory 6 cycles. Of course, enucleation would be necessary when the eye becomes quieter. CT4A, that is radiological features of optic nerve extension and extraocular extension. Contrast enhanced MRI is mandatory. Of course, optic nerve extension can be seen, but optic nerve sheath extension is mandatory because that may result in CNS manifestation. You can do primary enucleation if optic nerve extension is only about 5 millimeter or less. But if it is more than that, you should resort to neoadjuvant chemotherapy for 6 cycles and then do a safe enucleation. This was a child with optic nerve extension. Following neoadjuvant chemotherapy, optic nerve extension resolved. That would be the safest time to do enucleation. It does not subcategorize optic nerve extension. That's a fallacy of TNM staging. So this has to be also addressed in further modifications of TNM. You can find that this patient has optic nerve extension right up to the orbital apex. One more example of an optic nerve extension right up to the orbital apex. And when you give neoadjuvant chemotherapy to these children, optic nerve invasion resolves, making it safe for enucleation. Going on to enucleation itself, the trend to do enucleation has completely reversed. In 2005, we had 25% children world over, at least in the Western data, who underwent primary enucleation. Now we have much less. At least in India, the trend has come down from 95 or 100% enucleation rate. We do primary enucleation at about 20 to 30% eyes currently. What has really helped advance in enucleation is the refined technique, minimal manipulation technique, avoiding accidental perforation, aiming for a long optic nerve stump. Less than 15 millimeter is suboptimal. We have to aim for at least 18 or 20 millimeter. Longer, the better. Without much traction on the eye, without chiasmal damage with your traction, without causing much bleeding, you still have to get a longest possible optic nerve stump without cutting right at the apex, injuring the structures that pass through the superior orbital fissure. You should still get the long stump. The example is here. This patient obviously has optic nerve extension. If you were to stick to textbook 10 millimeter, transaction would be positive. Just our efforts to get a long optic nerve stump, transaction is negative. What if the transaction is positive? The child would need EBRT with all the attendant complication. Transaction negative, only adjuvant chemotherapy is required. So you have minimized adjuvant therapy because you have made efforts to get a long optic nerve stump. Primary implant is mandatory. That can at least give the child back the cosmesis that the child and the parents deserve. A short video of enucleation for those who are interested. Here we perform enucleation by the myoconjunctival technique. Myoconjunctival enucleation is good because then the implant centration is nice, implant extrusion and implant exposure are also minimal, and the implant motility is as good as porous polyethylene implant. A comparative study has already shown that static and dynamic osmosis are much better. 360-degree peritomy is performed as close to the cornea as possible. Dissection of the tenons in oblique meridia between the recti. Tagging of the extraocular muscle just short of insertion carefully so that you don't accidentally perforate the sclera. A second tag suture with 6-0 vicryl. In between that, the muzzle is disinserted. Each muzzle is treated similarly, except the obliques are simply hooked and disinserted. You don't have to tag them. Inferior oblique, a fleshy muzzle, cauterized and disinserted. I'm using cautery for all the transactions because I want minimal bleeding. Then a small relaxing incision in the temporal conjunctiva. prolapse the eyeball through the blades of the speculum, go between the lateral rectors and the eyeball with a 15-degree curved blunt tip tenotomy scissor, strum the eyeball, hit the orbital apex, lift the scissor by 2 millimeter, engage the optic nerve, and one bolt cut, all that is required. Identify areas of potential high risk factors such as a dilated vertex vein, measure the optic nerve stump easily 20 millimeter, assistant, careful closure of the posterior tenons with 6-vicryl, first barrier to the implant very carefully sutured. Myoconjunctival technique simply means that you're reinserting the muscle close to the respective phonesis. Is there any lag, Rolika? Is it okay?
That's fine. So there's very mild lag. That's okay, sir.
Okay. So all the muscles are myoconjunctivally reinserted. Anterior tenons is closed with fleshy bites, again with vicryl, and conjunctiva is closed with continuous key pattern suture, where the edges of the conjunctiva remain well opposed and everted, not inverted. So cyst formation, implantation cyst formation is minimal, well-fitting conformer, and a suture tarsography. You can leave this on for 6 weeks also, or as long as the suture stays. Otherwise, the child may remove the conformer accidentally. Now, what are the ways to get a long optic nerve stump? Lateral canthotomy and a conjunctival relaxing incision really help. Make sure that the extraocular muscles are transected completely. Prolapse the eyeball through the blades of the speculum and use traction sutures sparingly only to direct the eyeball and not to pull on it. There are studies which show in unilateral retinoblastoma when the eye was pulled and a long optic nerve stump was got. When these children became adults, when the visual field was done in the other normal eye, there were visual field defect, obviously because of the traction or attributed to the traction that the surgeon exerted. May be true, may not be true. Avoid enucleation spoon or scissors which take a lot of space and thus reduce the size of the optic nerve stump. Use a tenotomy scissor. If you are going by the lateral approach, then use a 15-degree curved tenotomy scissor. You can see the medial orbital wall is straight, that is the optic nerve, and that is the lateral orbital wall. So when you go with a 15-degree curved tenotomy scissor, you end up somewhere there with the lateral side, which is very good because you're not cutting through structures that pass through the superior orbital fissure. If you cut through structures that pass through the superior orbital fissure, there will be immediate bleeding, and also the implant will be immotile because you are cutting all the nerves that matter. Now, if you have a habit of going from the medial side, don't use a curved scissor because it will only reach up to there. So if you want the medial approach, then use a straight scissor and angulate it about 20-degree laterally so that you get a oblique stump like that. You understood, right? So approach is very important and the type of scissors that use is important. Always use a tenotomy scissor, not a enucleation scissor. In critical cases where you have to actually get the optic nerve right at the orbital apex and you want to be absolutely horizontal or nearly horizontal, then you can do a lateral orbitotomy bone cut also. Almost not required ever. Long optic nerve stump, this is by one of my fellows, 22 millimeter. Very easily they get 22, 23 millimeter. How do they get it? I don't know, but they manage it and without cutting the superior orbital fissure structures. Inspect the optic nerve and the sheath of the optic nerve. You can see that the optic nerve sheath is shiny. If it has nodular excrescences or does not move over the optic nerve, then that is affected. Clinician is the best judge for extraocular extension or the location of extraocular extension. So mark all areas of abnormal vascularity, thinning of the sclera, induration of the sclera, vascularization of the sclera. All these areas must be marked because you expect the pathologist to take sections from them. Otherwise, what the pathologists do earlier, what was mandated was pupillo-optic callet. You'd be lucky if you get high risk factors in a pupillo-optic callet. Some centers still practice the same. I would encourage all the centers who practice only pupillo-optic callet to shift to lateral callets and also red loaf so that there is a protocol for processing samples. So if you do that, then only you have the highest chance of catching all the histopathological risk factors. If you don't do that, you'll miss it. Now, additional benefit of marking these areas is that my pathologist is already prompted to take a section from the area that is marked. So catching extraocular extension or emboli within that particular blood vessel is much higher. If I were to prompt the pathologist, where could the potential risk factors be? And also they should look at where the tumor is. And then transillumination is a very rough guide, and then take sections from that particular axis. What is important is identification of histopathological risk factors, which are present in at least half the eyes that undergo enucleation in Indian circumstances. Anterior segment invasion, iris invasion, anterior chamber angle invasion is a soft risk factor. Ciliary body invasion is definitely a significant risk factor. Choroidal invasion of more than 3 millimeter in thickness and more than 3 millimeter in diameter is a significant risk factor. Optic nerve invasion beyond the lamina cribrosa is also a significant risk factor. In all these patients, we are supposed to give adjuvant chemotherapy. Adjuvant chemotherapy in every child who has histopathological risk factors. In addition, if the child were to have optic nerve invasion to the level of transection, scleral or extracellular extension, then you have to give orbital EBRT as well. Does it help? Earlier results were equivocal, but this particular study actually found that, which I did as a fellow, found that when we gave adjuvant chemotherapy, the risk of mortality because of metastasis reduced by 20%. In the group that did not get adjuvant chemotherapy, 24% was the risk of metastasis. In the group that got adjuvant chemotherapy, 4% was the risk of metastasis. So that make a significant difference. And that was corroborated later by the Children's Oncology Group study, of which we were also part of, and we contributed a large number of patients to this study. And then this became the standard of care. So adjuvant chemotherapy is now recommended for all children with histopathological risk factors. So enucleation is not the end. No, finally about orbital retinoblastoma. The incidence varies from country to country, but what is important is to classify these as primary, secondary, accidental, overt, and microscopic, so you can triage the management. Primary may be clinically evident with the proptosis that the child has, or radiologically evident with the MRI scan. Secondary is when you have enucleated and the child has an orbital recurrence. Accidental is when you have done an intraocular surgery on an unsuspected retinoblastoma and you find that there is orbital recurrence. Overt is when you find an extraocular component on enucleation, having missed it by imaging. Microscopic is when the pathologist tells you. Irrespective of what was the source of orbital retinoblastoma, mortality used to be 50 to 70% with a primary orbital exenteration. Now, why should we not do exenteration and why should we use multimodality therapy? Because the reasons are very obvious and are evidence-based. Systemic chemotherapy is unlikely to eradicate residual orbital disease. It only reduces it, it does not completely eradicate it. Orbital exenteration is good for local tumor, but it is not going to give surgical clearance as Hungerford showed. There would be residual tumor despite orbital exenteration if the tumor were to be very posterior. And also, orbital exenteration does not ensure that the microscopic metastasis has been taken care of. External beam radiation is unlikely to prevent systemic metastasis for the same reason. And also, there is histopathological evidence of viable tumor cells even in thysical eyes. So, after neoadjuvant chemotherapy, if the eye has become thysical, well, of course, part of the goal is accomplished, but bulk of the tumor is gone, but there would still be microscopic residue. So when we treat orbital retinoblastoma, we begin with high-dose chemotherapy, reduce the orbital component of the tumor. Then surgery is performed after a minimum of 3 cycles after radiological confirmation of the resolution of orbital component. Then we deliver stereotactic radiation and continue high-dose chemotherapy for 12 cycles. If it is secondary orbital retinoblastoma, chemotherapy protocol is the same, but surgery is not always necessary unless there is a residual tumor following chemotherapy. If surgery is necessary, then it is orbital exenteration. In accidental orbital retinoblastoma, there are 2 variations. If the tumor were to be manifest orbital, then it is managed like primary orbital retinoblastoma. If only a perforation has happened, suppose somebody has given an intravitreal injection or intravitreal antibiotic in an unsuspected retinoblastoma and there is no manifest orbital extension, then you use a less aggressive protocol. Suppose somebody has done a pars plana vitrectomy with 360-degree peritomy or a trabeculectomy, then you give neoadjuvant chemotherapy, enucleate, and do EBRT, and also give adjuvant chemotherapy. Overt is treated with adjuvant chemotherapy and external beam radiation. With all this put together in orbital retinoblastoma with multimodal treatment protocol, there is more than 90% survival. Showing you some examples, this child has orbital retinoblastoma. Following neoadjuvant chemotherapy, I went into athysis, at which time you do an enucleation with long stem, then give stereotactic radiation to the orbit, then give adjuvant chemotherapy. Optic nerve extension completely gone, again making it safe for enucleation. Child with anterior intracranial extension to cavernous sinus can also be treated with neoadjuvant chemotherapy. Now all that is left is at the superior orbital fissure, easily treatable. Bonus to these children is cosmesis. These children don't have to undergo orbital excineration, so they can use a custom ocular prosthesis. There's a secondary orbital retinoblastoma with even the eyelid involved. Implant has nicely settled back into its position. No surgery was required, only chemotherapy and radiation. So orbital RB also has a much better chance of cure currently. With all this put together, currently in many centers in India, including ours, the chance of survival has jumped up to 95 to 98%. Of course, there are unfortunate situations where metastasis does happen because of which children succumb. But overall, the prognosis has improved with protocol-based management. In India, about 1/3 of children still need primary enucleation. Chemotherapy, wherever it is done properly with the protocol, has up to 90% eye salvage. 95% of children who have eye salvage have some vision, and 50% have vision more than 20/40. That, of course, depends on the location of the scar and what kind of focal therapy have you used and how careful were you while doing it. These children, despite having such gross scars, with this scar, he's still able to draw well. Look at his drawing. He's using his residual vision very usefully.
Hi, I'm Deekshita.
Sound is heard or not?
Yes, sir.
Other enucleated macular scar is good at it, what she does. Right? So these children are very adaptable, and there are many such examples. This eye, one eye enucleated, other eye, she is a very active child and doing very well. There are, of course, socioeconomic barriers to treatment, intensive awareness program. No child is refused treatment, at least in our center, for financial reasons. We somehow manage with NGOs help, government help. Cost-effective management protocols are used. Government support is channelized to further help the family by travel concession, social insurance, etc., ensuring 90% compliance success. Future prospects, of course, lie in genetics, liquid biopsy, early diagnosis, improved focal therapy, focal drug delivery, and advocacy. This was a slide by Dr. Galli. This is just an example as to how she used genetics to help children. Then she was the front runner in the realm of genetics. 1996, father had bilateral retinoblastoma. In 1996, the first child was born, had bilateral retinoblastoma. Tumor mutation was detected. The second child in conception had a prenatal diagnosis, carried the same mutation. They refused, obviously, termination, and the child was delivered early because the first child was born with retinoblastoma. The second child was expected also to be born with retinoblastoma. Early delivery ensured that the tumor could be detected as the child grew into few weeks, and then the tumor could be lasered. Dr. Galli was fond of lasering at that time. Still, she maintained 6/6 vision. So this was the beauty of early delivery induced in a child with prenatal diagnosis of a known genetic mutation. Now, I am happy to announce that we have now the technology for non-invasive pre-implantation genetic testing, assisted reproductive technology. Pre-implantation screening is currently available in collaboration at our center, and we can offer it to parents who want to stop retinoblastoma from future generations. They can actually go for this particular technology. Liquid biopsy from the aqueous, blood, and CSF, of course, these are expensive, but they help in confirming retinoblastoma, confirming regression, and also detecting early recurrences. Early diagnosis of CNS disease is possible at least 6 to 8 weeks ahead of time with CSF liquid biopsy, and also the harbinger metastasis. Now, there are apps to detect retinoblastoma. We have many apps, AI-based apps and non-AI-based apps, which help detect leukocoria. These are mainly for parents.
You can tell from a child's eyes if he's happy, when he's sad, frightened, or when he's sleepy. You can tell many things from a child's eyes, including if he's got cancer.
Very simple television campaign in Brazil. This helped them pick up early retinoblastoma many folds higher. So basically, all your campaign should be very simple, creative, and effective. So that is very important. And of course, Rolika is here and she has made this. This is a very nice campaign. This won the best video award at the ISO yesterday. So this will help us educate parents, of course, and make early diagnosis more possible in at least in our situation. Creative, efforts like this will definitely help us. I have, I think for the uninitiated, at least those who know retinoblastoma, treat retinoblastoma, this is routine. What information I gave, everybody does practice, I believe. But for those not initiated, I think I took you down to the depth of the sea. And I don't want to leave you there. I just want to conclude saying, at least salient points are that trends in life salvage in retinoblastoma have been possible. Better trends have been possible by neoadjuvant treatment, adjuvant treatment, and multimodal treatment. So from 40 to 50% in 50s to 90s, we have brought it up to 95 to 98% life salvage, mainly because of these. Eye salvage has been mainly driven by intraarterial chemotherapy, intravitreal chemotherapy, and to a certain extent brachytherapy. From 30 to 50% eye salvage in the era of brachytherapy, now we have crossed 90% eye salvage with intraarterial chemotherapy and intravitreal chemotherapy. Vision salvage, of course, has been driven by intra-arterial chemotherapy, intravitreal chemotherapy, specifically topotecan, methotrexate is not conducive to good vision, ICG enhanced TTT, and gentle focal therapy, not extensive aggressive focal therapy. Gentle, triaged, well coordinated, well thought about focal therapy. So early diagnosis is the key to success. General awareness and screening of high-risk patients, app-based screenings, and also identify masquerades very carefully. In group A, you perform focal therapy. In group B, visually critical location, chemotherapy is the ideal initial treatment. Intra-arterial or intravenous does not matter in group B. In group C, again, intra-arterial or intravenous does not matter, but you have to give chemotherapy with local and focal therapy as appropriate, well triaged, and extramacular. D and D, of course, intra-arterial is better than intravenous chemotherapy if it is accessible to you. If one fails, you can do the other, but again, with very judicious, well-coordinated focal therapy. In high-risk cases, of course, I elaborated the protocol, and this is exactly what we do. In thyssecal eyes, primary enucleation, but MRI is mandatory to assess if there is orbital extension or optic nerve invasion. In patients with anterior segment involvement, you have to differentiate depository seeds from infiltrative seeds. Always do a UPM and then triage for management. If the child has neovascular glaucoma, if it's a younger child, then there is about 60% eye salvage. So attempt eye salvage in a younger child despite neovascularization of the iris, even buophthalmos or secondary glaucoma, unless there is a radiologically detected high risk factor. Then you have to do enucleation. Otherwise, these children have a reasonable amount of eye salvage. Older children, of course, enucleation is preferred. In children with hyphema and massive vitreous hemorrhage, careful observation is okay, but not prolonged observation, but careful observation after imaging. Then you do enucleation, histopathology guided adjuvant therapy. Aseptic orbital cellulitis, don't jump to do enucleation. It can be complicated. Give steroids, topical and systemic, neoadjuvant intravenous chemotherapy to render the eye thyssecal, then do a safe enucleation. For radiological features of optic nerve extension and extraocular extension, primary enucleation only if it is very limited, less than 5 millimeter. Otherwise, neoadjuvant chemotherapy and do a secondary enucleation. You still have more than 90-95% life salvage. Extraocular retinoblastoma, of course, nothing but multimodal treatment. So in conclusion, cost-effective protocol-based management by a multidisciplinary team. It takes a village to treat retinoblastoma, as Dr. Shields says, can help mirror eye and life salvage rates achieved in developed countries. We can actually achieve exactly what the Western countries have achieved with very cost-effective protocol-based management in centers where all the facilities exist. If you lack a particular facility, obviously that we compromise care. So it is best to refer it to multi-specialty centers wherever you find yourself inadequate in managing situations. Thank you so much.
Thank you so much, sir, for a truly comprehensive class. And I think we owe it to you for making sure that retinoblastoma sees a completely different face in the current times in India. We are extremely thankful. The panelists have few questions, so may I ask Dr. Mahima to please proceed?
Okay.
Thank you so much, sir. Wonderful talk as always. My first time as a panelist, and before this, I used to log in as a resident, and nothing has changed. I continue to remain in awe of you and your way of teaching as usual. So we do have a list of questions. In our Indian scenario, which one is more applicable, the classification system, international classification of RB or TNM staging?
Well, for staging, international staging is extremely good, right? But for group 5, especially group E retinoblastoma, then TNM is better. So there has to be a combination. If I were to be somebody who would do the staging, I would actually use a judicious combination and also kind of arrange TNM classification in such a way that it mirrors prognosis. Ultimately, it has to be a linear prognosis. It cannot be erratic. Anterior chamber seeds have a much better prognosis than a thyssecal eye. Obviously, thyssecal eye is lost, isn't it? So that kind of a linear progression is what is important when you classify a tumor because it mirrors prognosis. So some amount of adjustment in TNM is required and some components of TNM, if at all we practice international grouping, then that has to be brought into international grouping as well. So finally, if we have to have one single classification and perhaps TNM, because it is extensively used by the oncologists as well, TNM can be integrated with, because early parts of TNM are suboptimal, because see in group A, it is extramacular retinoblastoma without SRF, less than 3 millimeter, which readily tells you that the life is not at stake, eye is not at stake, vision is not at stake. Right? That clarity is not there in TNM for smaller tumors. For bigger tumors, TNM is more clear. So we have to have a merger of both.
And one
And
more.
that has to be
So,
evidence-based. So evidence is with us. We have all the data. Somebody has to work on.
yes, sir. And sir, in cases of retinoblastoma with germline mutations who are prone to develop secondary malignancies also, how and when should we start to screen them when we are following them up lifelong?
Yeah, so that is actually the job of an oncologist. We don't indulge in systemic screening ourselves because our expertise is domain knowledge is limited to ophthalmology and ocular oncology. So oncologists will start screening them on an annual basis. Every year the child would come and we ask them about history of lumps and bumps elsewhere in the body, and the oncologist is supposed to screen them every year until the patient reaches at least 30 to 35 years of age. And after that, also screening continues because osteosarcoma can be a late manifestation.
Yes. Thank you, sir. Anupama?
Yeah. So you discussed the revolution of advent of IVC in 1996, and then we got IAC. Do you think we are going to get more paradigm changes in the coming years? And what do you think, what do you expect them to be?
Well, I mean, things are changing and more targeted therapy, targeted to the mutation, perhaps. Molecular diagnosis is already there, and the easiest way to achieve molecular diagnosis is by liquid biopsy. So with that being accessible, then obviously targeted therapy is possible. Yesterday in the ISO webinar, you heard Matt Wilson speak about some of it, different forms of approaches. So these are all in work, it's happening already, in the sense that work is in progress and it may come to clinical culmination soon. We don't know when, but work is definitely in progress.
We hope that is very soon.
Great, sir. Over to you, Megha.
Thank you, sir, for this very inspiring talk as always. And this class is, I've seen this class come to life throughout my fellowship here, right from the time I joined. So it's a full circle moment for me. And so I wanted to ask that regarding IAC, there are multiple centers who follow different protocols. Some of them would choose IAC irrespective of it being unilateral or bilateral, while some stick to the principle of using IVC for bilateral and keeping IAC exclusively for unilateral cases. So would you please comment and elaborate?
Yeah, so if it's a slightly older child, say 1-year-old child with bilateral retinoblastoma, then perhaps bilateral intraarterial chemotherapy is fine. So it depends on the logistics and the expertise of the team that you're dealing with. If they're very quick in cannulating ophthalmic artery, then bilateral is okay, because the longer the general anesthesia, longer are the complications, correct? And also some amount of radiation exposure in bilateral situations, you want to avoid it as far as possible. It is very well known that younger children, less than 6 or 9 months of age with bilateral retinoblastoma, respond beautifully well to intravenous chemotherapy, right? So the advantage is that they're not getting any radiation because you're giving intravenous chemotherapy. And also this theoretical advantage of reducing the risk and even preventing pinealoblastoma in bilateral situations by intravenous chemotherapy. It's not possible with intraarterial chemotherapy. That is known. In fact, pinealoblastoma used to be much more common 20 years ago. Now we hardly see pinealoblastoma in post-chemo patients. There is most likely a causal relationship, and that is not possible with intraarterial chemotherapy. So in younger children with bilateral retinoblastoma, heritable retinoblastoma, I would prefer intravenous chemotherapy. But if it is bilateral asymmetrical, one eye group E, other eye group A or B, where one eye can be focally managed, other eye can be obviously managed with intraarterial chemotherapy better, say group E in the other eye, then unilateral intraarterial and the other eye being managed with focal is perfectly all right. So that's where it stands.
Thank you so much, sir, for the wonderful class, as always. So, I have two questions pertaining to plaque brachytherapy. So, we ideally use it in residual tumors and macular tumors and refractory to the other treatments. So, you had already mentioned that rarely it is used as primary treatment. So in case if we are using primarily, like what would be the indications?
Yeah, when the
That's one
child has
question. And
contraindication
the
for
second one,
chemotherapy,
okay.
when the child has contraindication for chemotherapy, yeah, whatever may be the contraindication, maybe after one cycle of chemotherapy, you discover that the child is not tolerating chemo well, or when you attempt intraarterial chemotherapy, the ostium of the ophthalmic artery may be abnormal, and the best of interventional uroradiologists may not be able to get into it, and there is a need to balloon deliver, which is suboptimal. Things like that, or ophthalmic artery getting into spasm at the first attempt at intraarterial chemotherapy, you don't want to experience it again with loss of vision, right? Intravenous chemotherapy having a contraindication because of some reason. So whatever. So there may be multitude of situations, clinical situations, complex clinical situations where chemotherapy may not be feasible. Then you would do a primary plaque. Or after abandoning chemotherapy for a specific reason, you can go to plaque if the tumor is amenable to plaque.
Okay.
You had a second question?
And what are the things, yes, sir. What are the things we usually keep in mind while deciding the dosage and also regarding the plaque placement?
Yeah, plaque placement is where the tumor is plus 2 millimeter, clear margins. And the dose is about 4,500 centigrade. But yes, the risk of radiation retinopathy is higher if the child has been treated earlier with intraarterial or intravenous chemotherapy, or the proximity between the plaque brachytherapy and the last cycle of intraarterial or intravenous chemotherapy is very close. The risk of radiation retinopathy is higher. So you may want to underdose the plaque a little bit or give prophylactic anti-VEGF, which we do anyway.
Okay.
Right.
Yeah.
Thank you so much, sir. Thank you for sparing your time. And thank you to the panelists for being there and addressing your questions. Thank you so much, sir. And we hope and we that the journey of retinoblastoma continues and it goes over 90% in the current scenario. And right now in India, you have revolutionized everything. And I think if everybody knows the state of art technology, everything that is available outside is also available currently in India. And the credit goes to you. So thank you so much, sir. They live and see, and a major credit goes to you. Thank you, sir.
Thank you so much.
Thank you to the audience for being here, and thank you so much, Anil ji, for the perfect streaming of the episode.
Thank you then.
Thank
Bye.
you. Very good night.